you, Andy. So this is an interesting thing that we all know, but we don't have much answers. I'm going to try to cover a few questions. Number one, what is the incidence of this associated meniscal and ligamentous injuries? Again, when we say the soft tissue injuries, we are not talking about the skin, the other things. We are talking about meniscus and the ligament injuries around the knee. How important to know, because again, as trauma surgeons, a lot of times it doesn't show up on the x-ray, so it doesn't exist necessarily, and we don't pay attention too much. Or do you need to do any routine MRIs to diagnose this? Because for soft tissues, we know that MRIs are better than to diagnose these things than any CT or x-ray because they don't show up on CT and x-rays. Can you predict the meniscus or ligament injury by looking at these x-rays or the injury patterns? And what to do with this ligament and meniscus injuries? Should you treat them acutely or delayed? I'm going to try to my best what to do with these ones. I think a question that comes up a lot of times with my younger middle-aged patients who has been in with some kind of sports medicine clinic in the past, especially, or they hear from their friends, they come in with a tibia plateau fracture and they ask like, are you going to order an MRI? This is a very typical question that every other tibia plateau fractures in my clinic that I get that question from the patient and I had to explain. Sometimes they come in with an MRI because they end up in the sports clinic and my sports colleague who's doing the clinic says like, oh, this is a fracture. I'm not going to see this patient. Can you see this patient? Which is a little different way to get these patients. So in that specific study that I am showing, so here, sorry, if I can go back. So this is basically a study that looked at all the studies who has tibia plateau fractures, and the focus was that what kind of injuries, meniscus and ligamentous injuries they have. And they gathered all the studies. They had 18 studies. There's about 800 patients, except two studies. Two studies has like 100 patients. The other studies had like 20, 30 patients. And I'm going to go a little more detail. So if you look at by just MRI, 93% of them had some kind of injury, positive injury on the MRI, meniscus or ligament or both injuries. Most common are ACL, 36%, and lateral meniscus, as we know, for like 50% in the meniscus side. Again, if you look at like this, if you're not getting an MRI, like in our trauma group, we are not getting MRIs for any of the tibia plateau fractures routinely, unlike they come in from through the sports side. We are missing all of this, and we are ignoring or neglecting them, to tell the truth, at the beginning at least. So there are some issues about all these studies that I have. I think the problem is that MRI overreads any severity of the injury, right? So any edema, any injured structure will call there's an injury. Like sprained ligament is at grade 1 or grade 2 injury is an injury per MRI. Unfortunately, most of the studies, and I looked at in detail in this meta-analysis too, like they don't separate the complete injuries and the lower severity of injuries. What matters to us and the patient in the long term, in my opinion, that is the grade 3 injuries, like the complete disruptions. If they have a grade 2 sprain of an LCL or MCL, etc., probably doesn't matter because with the recovery period, most of this is going to heal fine, and acutely probably you don't need to do anything. That's why probably most of these patients do well without any, at least in the short term, any problems, right? What we want to know, what is the real complete injuries on the ligament side? So I think this study is over-diagnose and overrate these injuries. So again, can you predict the meniscus injuries? Another topic. So can you predict that if there's a meniscal injury or not? The good thing, most of the meniscal injuries on the lateral side, almost always. I think there's two fractures that I'm showing here are two separate severity of the injury regarding the depression and the widening, right? I think we have an idea that if you look at, this is a clinical picture from one of my cases, like you see the depression on the one side, the articular side. If you look it up and you can see that this peripheral meniscal capsular avulsion, tears, is not uncommon with lateral plateau fractures. We don't get the MRIs because we're going to be there anyway, and we're going to, part of the exposure, we do submeniscal arthrotomy. If there's a tear, we will repair it, and we will incorporate in our closure. So we don't need to get an MRI for this necessarily. But can you predict them? Yes. The more severe they are, the depression-wise and the widening-wise, especially the depression, I think there's a higher chance or higher risk that there's going to be a significant meniscal injury. depression more than 6 to 10 millimeters and widening more than 5 to 7 millimeters is associated with a higher risk of a lateral meniscal injury. And if there's depression is more than 10 millimeter, then it's like 8-fold increased risk. So the more depression, more than 10 millimeters, there's a good chance that you're going to see on your exposure a lateral meniscus injury. The good thing, we're going to be taking care of them. How about the ligamentous injuries associated with tibia plateau fractures? It's more common with isolated fractures, actually. It's not more common with the type 6 and more severe injuries. It looks like the most of the energy goes through the bone and not the ligaments in these more severe comminuted ones. In isolated and displaced, isolated medial or lateral plateau and displaced one like the one you see on the up top X-ray, you can predict that there's going to be some kind of posterolateral corner or lateral corner injury plus minus some cruciate injuries if you think that the origin and insertion of these ligaments. Again, for lateral plateau fractures is on the MCL side. As you can see, the picture down here on one of the patients, that patient, the residents told me like the patient has a valgus stress of 30 degrees. I looked at the CT scan, I said like the depression doesn't seem to be that bad to cause a 30 degrees of valgus stress test, positive 30 degrees valgus stress test. As you can see, actually it wasn't just the lateral condyle falling into the depressed area because it wasn't that significant. There's some depression, but probably will cause about 10 degrees of the valgus stress positivity. There was an additional MCL injury in that patient too. Again, I think our job should be to diagnose these injuries. What to do with them is a different thing. I think we're going to do a ligament exam after the bony fixation, and I might show you some examples too. So this is a patient of mine, 27-year-old, supposed PVA, typical lateral plateau fracture after a PVA hit from the side. And I fixed it. After fixing it, as you see, once I tested, after the finishing my fixation of the lateral plateau, there's a significant medial gapping, right? This is a grade 3 MCL injury. Again, how to treat this? Obviously, MCL injuries heal better, but you have to treat this. If you recognize it, it may affect the recovery of the patient. MCL side heals fine. This patient was braced and did well, pretty well. And she was back to playing volleyball at 2 years follow-up after this, and her MCL was healed fine. So she was able to do a pivoting sports too. Again, these are not super common. I'm not trying to say that you are missing a bunch of them, but they are rare, but I think it's a good idea to fix them. Again, this is the patient that I was telling you about. This patient had a femur fracture and a tibia plateau fracture, and the resident was telling me that there are 30 degrees of valgus stress test. And I'm looking at the stress, the plateau views, and I'm like, 30 degrees seems to be very significant. And I examined the patient before bringing the fluoro in. Significant valgus stress, like the legs swing way lateral, and obviously the problem was the MCL injury. What to do for the treatment? If the treatment for the ligament injuries, if they are a big chunk of the bone and there's an avulsion of a collateral ligament, I think you need to fix them. It's fixable. They are minimally displaced. You can let them be, and they are stable. If they are displaced, you need to fix them because there's a good chance that they're going to be more unstable. Right? You see like the LCL insertion on the fibular head, that displaced. If you leave that alone, probably the patient is going to have some kind of instability. These are for avulsions. There are two main approaches about these ligamentous injuries that has been described in the past. Either you do it stage, right? You treat the bony injuries, you rehab them as you would, and reevaluate them on follow-up. Or treat all injuries at once when you are fixing them, which is called early total care. The interesting thing that about this complete care or early total care, fixing all the ligaments at the same time as the bony injuries, there's only one paper in the past with good kind of large series from Jim Stannard. At that time, it has been about 20 years almost, looks like it. And there's not much other than that being published, including by him too, which makes me wonder that probably this is not the best way to go because they are complicated. There's an increased risk of stiffness. There's a risk of infection because you are making more incisions. And the other thing is like it's hard to do cruciate ligament reconstruction or the repairs around the fixation of a tibia plateau. I think the advantages of the stage 1 is like decreased risk of stiffness and infection. The disadvantage if there are significant major injuries and they may take a longer recovery with delayed treatment or osteoarthritis due to the subtle instability. But I don't think this is going to develop in the next 3 to 6 months. Again, we are talking about this kind of stage treatment. If the patient has been fixed on a tibia plateau, has this posterior subluxation of the tibia, can get the reconstruction down in the line. Take-home messages. Acute MRI is probably rarely necessary. I don't think it's necessary, and we are not doing it in our group neither. Acutely, I think you gotta repair the meniscus tear, lateral meniscus tears, because it's part of the exposure anyway, and fix big bony avulsions of the collateral ligaments. Assess the ligamentous instability after you fix the bone intraoperatively, and you can reassess them at 3 to 6 months once they are recovering, because by 3 months they are starting putting the weight, and if they are going to return to sports, etc., and they are symptomatic. Thank you.